Hello, Dr. Chetan. Good evening. Hello. Hello, Dr. Chetan. You are muted.
Hello, sir. Yes,
Uh,
sir.
yeah,
Yes, sir.
we'll
Good evening, sir.
good evening. So we'll wait. Um,
Yes, sir. Yes.
So, good evening, everybody. Uh, is Dr. Panchwag there? And Dr. Jaydev? Dr. Vivek?
Good evening, sir.
Hi, good evening, Vivek. Nice seeing you.
Yes, sir. Good evening, sir.
So, I think it's 9 o'clock. We'll do the initial thing, and everybody can share their screen once I finish the introductory things. I'm just waiting for Dr. Panchwag. Today there was a case which we saw in hospital about whether it is vena for Leber infarct or not. You saw that image?
Yes, sir. I saw that. I think it is there.
Mm. But after a lot of discussion, I don't know, I told them to do MRS. I have a doubt whether it is a low-grade glioma.
Okay, sir. Okay.
And I discussed with Dr. Priscilla also.
Yes, sir. Yes.
Is Dr. Panchwag there?
Yes.
Good
Hello,
evening.
Dr. Gorthi. Can you hear me?
Yeah, I'm able to hear you. They're very welcome. So I think
Yes. Good evening.
good evening, and it's a wonderful dawn. Ladies and gentlemen, we have today basic neurosciences and journal watch. You all know who is Dr. Jaydev Panchwag. प्रणव अभी क्लास शुरू हो गया you know, is a brain surgeon and spine surgeon, very well known for trigeminal neuralgia interventions.
Okay.
And we are going to hear
Clear झालं का automatically?
we are going to hear from him about trigeminal nucleus and applied anatomy of trigeminal nerve. And also we have with us Dr. Vivek Sriram Murmukar, who is a MD radiologist from GS Medical College and KM Hospital, the gold medalist from MBBS 2012 and radiology gold medal in 2016. He did DM neuro imaging and intervention from Bangalore. Former resident, senior resident in AIMS Delhi and KM Hospital. Currently, is with us in Bharti Hospital, and he's panel consultant for major hospitals across. And Dr. Vivek will be talking to us about the radiological aspects of trigeminal nerve. Then we have Dr. Aradhana speaking to us about optimal timing of resumption of anticoagulation of tri-CH in patients with mechanical heart valve. And she's in SR Neurology in Sayadri Hospital. It will be journal watch, as a brief journal watch, and followed by Dr. Chetan, SR Neurology from Sayadri Hospital, who will be talking to us about early versus late anticoagulation in minor, moderate, and major ischemic strokes with atrial fibrillation. So, with these introductory things, people are joining that Panchwag. You can share your screen. I'll stop mine.
Yeah, no? Share screen. Yeah. Also. Yeah, is it okay, Dr. Gorthi?
Yeah, it's visible. Fantastic. It's coming nicely. Can put it on a slideshow.
पुढे टाकायला पाहिजे, मोठं करायला पाहिजे.
At the same time, we are live on YouTube also. People will be seeing from there also, and it's going to be there for subsequent days also. Not going to remove it.
So you let me know when you say I'll start.
Yeah, there are all the students are joined. I was just looking for Dr. Devte who wanted this talk.
Yeah.
Just give him a ring.
Escape. Stop share कैसे करता हूँ? शेयर करूं? परसों में 1 मिनट तो Dr. Gorthi, can you hear me? तो वॉइस ऑन केलं ना?
Dr. Yes. Dr. Jaydev, you are clear and visible. We can start.
Okay. You can see the entire screen of the presentation
Yes, we can see. We can see entire
because there
screen.
was some, recent update in Zoom on my computer.
Okay.
So there are some different buttons. So I'm just, confirming that you can see
Yeah,
me.
we are able to see the first slide, your introductory slide.
Yeah. Okay. You let me know when to start.
Yeah, I think because we will start and people are joining, they'll keep joining. And
So if you want to have a radiology first, maybe Dr. Divtek can join or something like that.
or shall we do one of the articles first so that others can join?
All right.
Yeah?
All
Okay,
right.
we'll wait.
All right.
Dr. Aradhana, you take up your first your article. Okay, you share your screen. Dr. Panchwag, then you can stop sharing your screen for some time.
Sure, sir. I'll do that.
Aradhana, are you able to share?
No, sir. I can't find any button here to share the screen.
It should be on your laptop only. We have allowed everybody to share. Hari, can you direct her? Can you help her?
Yes, sir. Ma'am, it should be there on your right lower half of your screen, share screen.
Participants, chat, reaction, AI companion, and more.
Next is share.
There is share, ma'am. Share with an arrow upwards next to reactions.
Otherwise, Chetan, you can do if you are ready. In the meantime, she'll find out what's the problem.
Yes, sir. Yes, I will try.
Chetan, if you're able to share and start.
Yeah.
Yeah, yours is visible. You put it on the slideshow.
Yes, sir.
You got about 12 minutes time to finish your talk. Okay.
Yes, sir.
Hmm.
This was the article published in the last year in the NEGM. Early versus late anticoagulation in minor, moderate, and major ischemic stroke with atrial fibrillation. This is the post-hoc analysis of the same the trial that was ELAN trial, randomized clinical trial. This was published in the JAMA. So atrial fibrillation is a common cause of ischemic stroke and is associated with high risk of recurrent thromboembolic events, especially shortly after initial stroke. So there is uncertainty about when to start direct oral anticoagulant therapy in patients with acute ischemic stroke and atrial fibrillation, because there is a high risk of recurrent ischemic events and hemorrhagic transformation in the early post-stroke period. So this trial studied early versus late initiation of direct oral anticoagulations. So they classified the strokes based on their size. Larger infarcts are associated with higher risk of early recurrent ischemia and hemorrhagic transformation, complicating the decision when to start anticoagulation. So this trial enrolled the patient, and they classified them according to the infarct size, and they started they made two groups, and in early group they started direct oral anticoagulants in the early phase, and in the late phase. And the analysis was done. Based on that, there were two groups in the ELAN trial: early treatment group and late treatment group. In early treatment group, the patients included the patients were classified for minor and moderate stroke. Within 48 hours, direct oral anticoagulants were started, and in major strokes, on day 6 or 7, it was started. In the late group, in a minor stroke, on day 3 or 4, in moderate stroke, on day 6 or 7, and after major stroke, on day 12, 13, or 14. So study duration was between October 2017 and December 2022. Imaging, neuroimaging, which were used more was mostly CT-based criteria. MRI was used in around 40% of cases. So they classified the stroke based on in 3 categories: minor, which is less than 1.5 centimeter in the anterior or posterior territory; moderate, more than 1.5 centimeter in the anterior territory, but not involving the entire middle or anterior cerebral artery territory; and major, involving the entire middle or anterior cerebral artery territory, or more than 1.5 centimeter in the posterior circulation. So primary outcomes which were studied included composite of recurrent ischemic stroke, symptomatic intracranial hemorrhage, systemic embolism, major extracranial bleeding, vascular death within 30 days after the index event. Secondary outcomes which were studied included composite endpoint within 90 days after the index event, new clinically apparent ischemic or hemorrhagic cerebrovascular events, non-major bleeding, vascular death, modified ranking score, that is MRS score at 30 and 90 days, and functional independence, that is MRS score 0 to 2 at 30 and 90 days. The analysis of ELAN trial data compared the primary composite outcomes and secondary outcomes between early and late direct oral anticoagulation initiation in participants with minor, moderate, and major strokes. The outcomes were measured within 13 and 90 days after the index event. So key takeaways were early and late direct oral anticoagulation initiation showed similar outcomes for minor and moderate strokes. Early treatment may have lower risk of adverse outcomes in major stroke patients, and recurrent ischemic stroke was the most common adverse event. There was no significant difference in severe adverse events and functional outcomes between early and late treatment. So this was the primary composite outcome. Primary composite outcome included recurrent ischemic stroke, systemic embolism, major extracranial bleeding, symptomatic intracranial hemorrhage, or vascular death. In early treatment group, it was 2.9% and later 4.1%. Odds ratio of 0.7, which was not that significant. Secondary outcomes which were studied include recurrent ischemic stroke, major extracranial bleeding, and symptomatic intracranial hemorrhage. That was also not that significant statistically. And at 90 days, this composite outcome, 13.9% early treatment and 15.8% in the late treatment was seen. So there were fewer primary outcome events, that is recurrent ischemic stroke, symptomatic intracranial hemorrhage, systemic embolism, major extracranial bleeding, and vascular death in participants who received early anticoagulation across all infarct sizes. However, there is still uncertainty about the benefits of early anticoagulation due to the imprecision of the estimates. So comparing with other trials, the timing trial randomized participants to early, that is less than 4 days, versus late, 5 to 10 days, initiation of direct oral anticoagulation without stratifying by infarct size. And in ELAN trial, they classified based on the infarct size and suggest that delays in the anticoagulation, especially in major stroke patients, might lead to more adverse events. So current guidelines suggest withholding anticoagulation for 12 to 14 days in people with major stroke, but the ELAN trials finding indicate that earlier anticoagulation could be beneficial, particularly in major stroke patients. The prevalence of symptomatic ICH was low in both early and late treatment groups. No participants with major stroke randomized to early treatment had an symptomatic ICH. So with long-term effects, in participants with minor stroke, those randomized to late treatment had more outcome events occurring more than 1 month after the stroke compared to those in the early treatment group. So further studies should investigate the long-term effects of earlier direct oral anticoagulation initiation. So conclusions. This study found that early anticoagulation treatment led to lower incidence of primary outcome across all infarct sizes group. This trend was most notable in individuals with major strokes, suggesting potential benefits of early treatment. So despite this study not being designed to prove non-inferiority or superiority, the results indicate minimal harm from early treatment. This finding supports the idea that early administration of direct oral anticoagulation, as done in the ELAN trial, is a reasonable and potentially beneficial strategy even for patients with severe strokes. Yes, thank you.
Thank you, Chetan. Thank you. I think a very important issue, still debatable. I invite comments from participants and faculty first. Anybody wants to watch their comments? They can unmute and talk. Chetan, the odds ratio is 0.7 with a wide confidence interval,
Yeah.
suggests that
Yes, sir.
it is not conclusive on either way,
Yes.
early
Yes,
treatment
sir.
versus later treatment. But
Yes.
early treatment seems to have more complications in minor strokes in the later stages if you don't treat. Or what is that indication? Saying that if you
Uh,
early cases, recurrent ischemic stroke is major, of course. That is not our major problem, because ischemic stroke we are trying to prevent by NOACs,
Yes, yes,
right? So major extracranial hemorrhage, symptomatic
hemorrhage. Yes,
major issues.
yes,
So there is a trend towards
yes.
initial,
They, yes,
it's not conclusive. Bolo. Yes, you tell.
yes. They told that there are no as such major adverse events as compared to early versus late initiation of anticoagulation.
Yeah.
Yeah.
That's good. Any of the faculty wants to contribute anything?
I have one question.
Vivek, bolo.
Which anticoagulation they have used? And second thing,
Uh,
how they
yes.
divide the stroke in the three categories? You have any representative images to show us?
Yes, actually, they are present on the website of the ELAN trial, sir. The
Okay.
representative images.
Okay.
I will forward, sir, later.
Okay. Okay. And which
Yes.
anticoagulation drug they have
And
used?
regarding the mention, they didn't mention the exact names of the antibodies in the trial, sir. I will.
Okay.
Yes, sir.
So they might have used warfarin or they might have used the Novax also.
NOACs, we don't know.
These most of these patients are non-valvular AF. So mostly they might have used NOAX because
Okay.
non-valvular. Yes.
Okay, I think we'll check it later. And Dr. Vivek, can we go on to the our main presentation?
Yes, sir. Yes, sir.
Dr. Panchwag, you can start. Chetan, you stop sharing your
Yes, sir.
screen.
Yes, sir.
Thank you very much.
Thank you.
You stop Chetan, you stop your sharing. Yeah. That Panchwag, you want to start?
Yeah.
Yeah, right. Now we have enough crowd. I think many people have joined.
Yeah, it's okay.
Yeah.
So I'm just sharing my screen.
Mhm.
Can share on that? Huh? Share one. Yeah, you can see, I hope.
Yeah. We are yes, we see now. Very nice. Nice and clear.
Yeah. So basically, Dr. Divte asked me whether I will speak on trigeminal nucleus. But it was just day before yesterday, and trigeminal nucleus is a very big nucleus with lot of connections in the brainstem, and with lot of implications in various cephalalgias and other problems. So it is very difficult to talk about trigeminal nucleus in detail today, but I will present my experience of trigeminal neuralgia and the cisterna segment of the trigeminal nerve with the anatomy, and I will just summarize some points about the trigeminal nucleus. So is it okay, Dr. Gorthi?
Yeah.
I'll speak.
It's good.
Yeah.
Some
So,
aspects Vivek also covers in radiology. No issue.
Yeah. So I will start with, especially I always feel that the neurology colleagues in, the subjects which are on the borderline of neurology and neurosurgery, it is very important for, them to see the findings which are there. And that I think helps in decision making and also adds some interest to the subject because unless you see the things actually in action, you many times do not get the exact perspective. Now, I will just start with this view of the trigeminal nerve seen through the endoscope, and uh, just to show you the possibilities which are available today. You can see a in-depth view of the trigeminal nerve, the pons, and the Meckel's cave, the nerve entering in the Meckel's cave here. And there are two big blood vessels which are near to this. There is an artery which we are trying to separate here, but it is not really compressing anyway. There is a big vein which was on the root entry zone, and it was actually causing the neuralgia. This is just a starting introductory slide. And coming to the trigeminal nerve itself, as we all know, it is extremely complex nerve, and its nucleus extends from midbrain to the upper cervical spinal cord. So it spans the entire brainstem, and not only the brainstem but the upper cervical spinal cord. I think it is very important to consider the uppermost portion of the cervical cord sometimes as part of the brainstem if we want to really understand the pathophysiology of many of the cranial and cervical pain syndromes. And that's why it is a very complex now, as it is spanning, the nucleus is spanning all along the brainstem. It is forming a lot of synapses and connections with different areas of the brainstem, different cranial nerves, and there are different reflexes like trigeminal, cardiac reflex, etc., which happen. Important things to remember about trigeminal nerve, I will just summarize as I go forward. So this nucleus includes the trigeminocervical nucleus also, and it is very important to remember for all the neuroscientists because it is not only a mediator in the cranial pain syndromes, but it is also a mediator in the cervical or neck pain syndromes. And many of the cervical or neck pain complaints associated with different trigeminal autonomic cephalalgias can be explained by this fact about the trigeminal nucleus. So especially for the postgraduate students, it is very important to remember. It carries sensory, motor, and autonomic fibers. The autonomic fibers supply to the cranial vasculature, which is extremely important in pain generation as well as autoregulation. It has been the center of a lot of controversies, the trigeminal nerve itself. And especially while, okay, sorry. So it has been the center of a lot of controversies and theories in explaining various disabling cephalalgias. As you can see here, the most rostral nucleus is the mesencephalic nucleus. Then there is a motor nucleus. There is a main nucleus of the trigeminal nerve here, and there is a descending nucleus of the trigeminal nerve. Now, this descent apparently goes up to C2, but it has been reported to go up to C4 also. And that is why the trigeminal pain syndromes can be traced down to the pathologies of C4. The classical description of onion peel in the lowermost portion of the trigeminal nucleus is demonstrated here. And I always feel that if we look at this onion peeling in this posture, when a person is looking up, then it suddenly makes sense. Because nose and mouth, these are the uppermost portions, and this is represented in the most cranial part of the lowermost nucleus. Then in between part is represented by the intermediate part of the nucleus, and the lower part represents the almost the entire mandibular division. And if you consider that just below the mandibular division there is C2, then you will understand why this has evolved in embryogenesis like this. And it will also help many of the students to remember this in a more meaningful way. So, few of the points important to remember from clinical perspective are first is that the lateral portion of the nose, the ala of the nose, is supplied by the V2 or maxillary branch, whereas the nose almost up to its tip in the midline is supplied by the V1 branch. So you will see the zoster herpes eruptions of V1 right up to the tip of the nose. But the ala is supplied by the V2. This is important to remember in deciding which branch of the trigeminal nerve is involved in diseases like trigeminal neuralgia. Another thing that one has to remember is that the lower margin of the mandible, the lowermost, the inferior surface of mandible, is not supplied by the trigeminal nerve. We know about the angle of mouth, angle of jaw, but one has to remember that even this margin, the lower margin, is not supplied. So many times people with glossopharyngeal neuralgia point towards the throat and the lower portion when they are describing, and then sometimes we get confused whether they are talking about the trigeminal pain or the glossopharyngeal pain. So glossopharyngeal pain at times can spread right up to the lower portion of the throat. Third point that we need to remember is that tragus is included in the V3 division distribution. And this is responsible for this being one of the important trigger factors in trigeminal neuralgia. Sometimes we have seen that this ear representation of the mandibular branch extends right into the ear, that external ear. Otherwise, the typical neuralgias which come with severe lancinating pain in the pinna are attributable to the nervus intermedius neuralgia. Very important, because when we are doing surgeries, we need to know which nerve is actually responsible. And for these intermediate neuralgias, many times we check both the nerves and we decompress both the nerves, because this is the junctional area between the nervus intermedius, the glossopharyngeal nerve, which supplies the deeper part of the ear, and the external part, the tragal part of the ear. So this is the meeting point of all these three nerves. And when the pain occurs here, one has to be very, very careful while attributing from where the pain is, coming. Fourth point is to remember, also for the exam purposes for postgraduate students, is the cornea is normally supplied by the V1 division, but in some people, the entire cornea can be supplied by V1 division. Normally, it is described, in some patients, the half of the cornea is supplied by the maxillary division. So, cornea is also supplied by both divisions in some people. So, it is important to remember. The fifth part to remember is the posteriormost boundary of the sensory distribution of the V1 and the V3. It goes right behind the coronal suture. It is wrongly described in some textbook as reaching up to the coronal suture, but it actually reaches up to the vertex. If you join both the auditory metatarsus across the scalp, you will get the distribution of the posteriormost distribution of the trigeminal nerve. This is one of the famous pictures also printed in Dajong, where they had charted the distribution of the trigeminal nerve, and you can see a massive sparing of the angle of jaw and right up to the inferior margin of the mandible, which were supplied by C2, C3. And so there is a variability, and variability is always possible. It is important to remember this. You see this line going right up to the tragus. Tragus is a very, very common trigger point in trigeminal neuralgia. So this nerve supplies the nociceptive fibers not only to the dura mater and its blood vessels, as was taught earlier, but the recent research has proven that it also supplies the pia mater and its cortical blood vessels. as the blood vessels dip down into the brain and enter the Furcault spaces, they lose their innervation from trigeminal nerve. So even the pile diseases can cause, uh, referred pain, and they can take part in different trigeminal pain syndromes. Another point to remember is there is variability in the structure and functional fiber distribution of the trigeminal nerve. For example, it has been proven that in some people there is connection between V2 and V3 divisions after the ganglion. And so there can be some confusion while charting the trigeminal nerve. It is important to remember this variation. And the third point to remember is amongst the cranial nerve, it has the most variable length of the myelination transition zone. And what it is, I will come to it shortly. So this is the operative picture of the trigeminal cisternal portion. This is the left-sided trigeminal nerve seen through the retromastoid approach. This is the facial nerve and the vestibulocochlear nerve. This is pons, and the cerebellum is being retracted by this suction cannula. You can see a curving superior cerebellar artery and a branch of the AICA or ICA, both pinching the nerve between each other. And you can see how roomy this area is. By the way, you can also see a sixth nerve in the depth as it is entering into the canal. Very beautiful picture of sixth nerve. But, you see a very roomy area here, but this is not always a fact. There is, as I said, extreme variability. And I will show you the variability. Important to remember that the portio major or the sensory root of the trigeminal nerve, which is the broader of the two, has got a definite laminated arrangement of the V1, V2, and V3 fibers. It is important to remember this because in some pain syndromes like severe post-MS trigeminal neuralgias, there is no other way but to cut specific areas of the nerve. And one has to remember that these areas can be actually predicted in the course of the cisternal portion of the trigeminal nerve. So this anatomy is very important to remember. The motor root is usually superior and anterior to the sensory root. But again, trigeminal nerve can come in different shapes, angles, and sizes. And with age, it can also rotate. It can become thin, it can rotate, and it has got variable appearances both on microscopy and on radiology. So as I said, size, animation, anatomical variations, shape, and angle of the trigeminal nerve can vary. As you can see in this picture, there is a almost transparent trigeminal nerve, very, very thinned out trigeminal nerve, below which there is an artery. With age and persistent arterial pulsations, this has become ribbon-shaped or ribbon-sized. This is a trigeminal nerve with completely separate roots. This is a motor root which is separate from the sensory root, and it is a known variation. Here you can see almost straight trigeminal nerve, very long, as against that shorter nerve, very less space in the prepontine and lateral pontine cistern. You can see extreme shortness of the trigeminal nerve here. And so they come in different shapes, different sizes, and different angles. And this contributes to variability of the symptoms and presentation. This is a typical endoscopic picture of the trigeminal nerve. These are the motor rootlets. This is the sensory root. This is pons. This is a swing of the AICA, and this is a Meckel's cave. So one will know why actually it is called as cave. It is entering into the cave to form the Gasserian ganglion. So as the nerve is emerging from the brainstem, the myelination pattern of the nerve is changing. And it is very important to remember this because this change of pattern from the central myelin, which is formed by the oligodendrocytes, to the peripheral myelin, which is formed by the Schwann cells, is the most delicate zone. And embryologically, it is formed in different time zones during development of the fetus. The central myelination appears first, then there is peripheral myelination, and then there is the junctional zone myelination. So this is a very important concept to remember, embryological and anatomical concept, because this is at the root of the trigeminal neuralgia or other neurovascular conflict syndromes like hemifacial spasms. Now, in these people, this zone, also called as Obersteiner-Redlich zone, is defective in its formation. Of course, it is definitely more prone for faults because it is a fault line, as to say, because two different patterns and in between pattern, which appears afterwards, almost as an afterthought, can remain deficient in some people. And this is one of the factors, one of the two important factors which are required for production of neurovascular conflict syndrome. So the central myelin, peripheral myelin transition zone is referred as Obersteiner-Redlich or Glial-Schwann junctional zone. In in the trigeminal nerve, it is the longest. Starting from the brainstem, it can reach right up to the Meckel's cave. It is very important for people to remember this. Why, I will tell you afterwards. It's a very, very long zone in trigeminal nerve. As compared to trigeminal nerve, this zone is shorter in facial nerve. So the compressions uh, near the brainstem on the facial nerve are able to cause hemifacial spasms, but these peripheral compressions do not cause hemifacial spasms. Again, the implication being in surgical science. Glossopharyngeal nerve, as you can see here, this is the glossopharyngeal nerve. This is the vagus. So this neuralgia should be aptly called as glossopharyngovagal neuralgia, not only glossopharyngeal neuralgia, because it's a combined neuralgia, not only glossopharyngeal neuralgia. And there is a branch coming from the vertebral artery. This is pica, PICA, and it is making a loop and going and stretching the vagus nerve and some fibers of the glossopharyngeal nerve which are still in this bundle. And but the transition zone in glossopharyngeal nerve is very short, and even shorter is vagus and nervus intermedius. Nervus intermedius neuralgia, very important to remember because it can be confused with other pain syndromes. So how is trigeminal neuralgia generated based on the anatomy and embryology and physiology? So as I said, first requirement for the neuralgia to develop is a defective transition zone. And in one person, it can be defective on one side, whereas perfectly normal on the other side, developmentally. So this is one factor that is required. The other factor that is required, of course, is this kind of compression. As you can see, a thinned out nerve, trigeminal nerve here, a big curving superior cerebellar artery, which is deeply indenting into the belly of the nerve. There is a vein which is descending on pons, which is causing counter compression. And then there are other elements. This picture is taken after a lot of dissection. So these structures have been skeletonized. We had to spend nearly half an hour to skeletonize each and every structure. So they were in one bundle. So this is another factor that is required in production of trigeminal neuralgia. With incessant pulsations of the arteries or the veins on the nerve in the area which is deficient in myelin has a potential to cause progressive demyelination and short circuiting between the fibers, causing the typical neuralgic pain attacks. And that is why many of the times I hear these questions coming either from the radiologists or coming from neurologists or other people is the demonstration of blood vessel enough to diagnose trigeminal neuralgia? I also get many patients coming to me with reports saying that there is neurovascular conflict but no neuralgia, asking me whether they will develop neuralgia. So just to put the facts in place, in our series of 1800 patients of TN, we have found that 30% of the people have neurovascular demonstrable conflict on the opposite side, that is asymptomatic side also. So that side has never become symptomatic in last 20 years in them. So mere presence of blood vessel or compression or distortion of the nerve doesn't mean anything. It has to be coupled with a genetic predisposition in the form of defective transition zone between the central myelin and the peripheral myelin. And along with that, there has to be a counter compression most of the times, which gives the final result to the pain of trigeminal neuralgia. Also, as Peter Janetta very famously said in 1980s, that the size of the blood vessel doesn't know how much to compress the nerve. So even small but critically placed arterioles and venules on the deficient transition zone can cause neuralgia, which is the reason why even if a clear-cut large vessel is not seen on the MRI, but there is definitive trigeminal neuralgia, there is a need for microvascular decompression. I'm not saying this has been said 20 years back. Only thing, people have not taken cognizance of these very illustrative and educative remarks by the pioneers. And so this is the cisternal zone. Sorry, this is cisternal zone. You can see trigeminal nerve getting compressed between a very uh, large curving loop of the superior cerebellar artery on one side and counter compression by the vein on the opposite side. You can see the trigeminal nerve sandwiched between the superior cerebellar artery and a PICA loop, almost pinching between these two, the nerve and the transition zone, obersteinal Redlich zone. This is a multiple vessel compression of the trigeminal nerve, very severe neuralgia. By the way, we have found and reported that the neuralgias which occur because of the venous compression are more severe, tend to be more like type 2 neuralgias, constant pain punctuated by severe attacks, and it has got more burning quality in them. So this is a characteristic of venous compression. You can see the root of that is root entry zone compressed by a blood vessel here. So this is a very small arteriole, which is very critically placed, and there was a thick arachnoid which was encapsulating the whole thing. And these arterioles are almost never seen on the MRI. This is a very small size. This is multiple times large picture through microscope. These small arterioles are not seen and they do indent deep into the transition zone. This is a very severe compression by two large veins and compressing the trigeminal nerve in between them and causing severe neuralgia. This is an example of a venule which is tethering the root entry zone of the trigeminal nerve and causing trigeminal neuralgia. Ectatic basilar artery, which is displacing the trigeminal nerve up against the tent and the vein, causing severe trigeminal neuralgia. So that is why radiology is not always reliable here. It is very important to remember this. Then, we will be able to guide people properly. And this applies also to other nerves, very much applies to other nerves. Though in hemifacial spasms, we prefer to see the arterial compression more frequent than the trigeminal nerve. So just to summarize our experience in last 19 years or so, there have been 1,800 cases of trigeminal neuralgia treated by MVD, 650 plus cases of hemifacial spasms, 38 cases of glossopharyngeal neuralgia, and 6 cases of tinnitus. And we have kept the records of all these cases by drawings, and these drawings are made immediately after surgery. So, we don't miss anything because of, the time elapsing in between. And these drawings have helped us enormously to classify these neuralgias into different types and giving some, infusing some sense in decision making. What I want to show here is compression of the motor roots by a curving artery, which is seen here in endoscopic view. And these roots are not ending here, but going right below. Peter Janetta has always also remarked that neuralgia, when it occurs with combined compression of motor and sensory roots, is more severe, because sometimes the autonomic fibers tend to pass through the motor root, and then at the later stages of the nerve progression, separate and then go to the desired level. So the important thing again to remember is a wide variability of the vasculature of the posterior fossa, wide variability of the size of the posterior fossa. The size in Asians is supposed to be smaller volumetrically, pushing all the structures into each other and making them more prone to these syndromes. And you can see these photographs, and you can see how crowded this area can become, and the nerves can get compressed. So just a summarizing slide of the results. These are the cases operated between 2004 to 2024 by a single surgeon, with minimum follow-up of 4 months and maximum of 19 years. So 98% had excellent relief, total uh, control of pain. 1% had mild and easily controlled pain, not interfering with life. And 1% had recurrence severe enough to warrant a rescue procedure or resurgery or something like that. And these results were presented in joint meeting of Indian and American Association of Neurosurgeons in 2019, and was also demonstrated in the Japanese Neurosurgical Society near about the same time. So these are the drawings which we make, on whatever paper we get after surgery. We have made these drawings over the period of time and kept the chart. This is one of the classical examples of how a pulsating artery sandwiching the nerve between itself and the vein on one side can cause almost 70 to 80 times hammering of the nerve. And again, this is during the later stages of the surgery, after the arachnoid has been dissected completely and the structures have been skeletonized. But one can very easily see the pulsations hitting the nerve. And this is a Teflon, uh, a soft Teflon, which is kept and rotated to prevent it from slipping. And we also nowadays use glue. This is another example of how a vein uh, can cause severe neuralgia. You can see a very short uh, nerve here, and you will shortly see a vein which is passing through the rootlets. And since it was not of a large caliber, we decided to coagulate it, which is entering into the rootlets, as you can see. And it was curving and coming out from the opposite side. So this was a typical severe venous-induced neuralgia, which was completely cured. This is example of how ectatic basal vessels, cause neurovascular conflicts. Again, our thesis on this is that, and this has been written and presented by us, is that the smooth surface of a large ectatic vessel does not cause neurovascular conflict. There has to be a vessel which is sandwiched between this smooth curve and the nerve. You can see thinned out trigeminal nerve here. And as we are separating the ectatic vessel here, you will shortly see that there is a sandwiched vessel. So one has to specifically hunt for this. If one doesn't hunt for this and just decompresses the blood, big vessel, then this will not only not go, but this decompressing Teflon will itself press the intervening blood vessel more into the nerve. So these are some of the reasons why there have been variable results in microvascular decompression surgeries. Now, one has to really understand what causes this compression, where the compression is most likely to be, and how to decompress this. You can see this small arteriole and this thinned out ribbon like trigeminal nerve and this big ectatic vessel here. So not only have I pushed the big ectatic vessel, but I need to decompress this smaller arteriole. If I put a sponge between these two, it will in fact press the arteriole again more into the nerve. So I have seen some, people operated outside coming with increased severity after surgery. That is because of misplaced Teflon. Also, as Janetta famously said, uh, very rarely we see a negative exploration. In my experience of 19 years, I have seen 2 cases. I'm sure I must have missed multiple sclerosis or something in these people history, and we did not find a compression. Janetta said that if you don't find compression in a classical case of trigeminal neuralgia, you have not searched enough. And he was the pioneer and had largest series in 1990s, and our experience completely corroborates with that. Uh, Now, this is an example of how a big curving vessel can enter into the belly of the nerve and cause neuralgia. So this is the nerve deformed by a big vessel entering into the belly and compressing the root entry zone or obstinal Redlich zone. And as I separate this from this curving vessel, you will see how relieved this nerve is. Now, this is the deformed nerve, and you can actually see pulsations here. You can actually see pulsations here hitting the nerve from within. And as this loop is removed, there is complete disappearance of the pain. And of course, then the Teflon is placed. So, based on our video records and our drawings, we have classified this. This is more technical, but I'll just run through this. So, this is a group of large curving superior cerebellar artery. Then other group is a downward looping superior cerebellar artery, and causing these different variations cause compression of the nerve in different regions and are responsible for differences in the distribution of the pain. You see example here with a pinching of the nerve between the two arteries. There's a third group. Fourth group is compression by pure AICA. It can happen, though relatively rarely, and it causes very severe V1 neuralgia. Large vein with counter compressing artery and nerve sandwich in between. The fifth group. Sixth group is that of arterioles, not seen on the MRI and indenting deeply. The seventh group is that of the veins. Eighth group is that of a small venules causing critical area compression. Ninth is the veins very much distally in the trigeminal nerve near the Meckel's cave. As you can see, a big venous varix compressing the trigeminal trigeminal nerve away from the brainstem. But since the obstinal Redlich zone in trigeminal nerve can extend right up the Meckel's cave, there remains a possibility of this happening. So important to remember, only 0.3%, but important group in our research. The ninth group, 10th group is suballar vessels, the vessels which are trapped between the cerebellum and the nerve, and which are missed during exploration of the surgery of trigeminal neuralgia. Basilar ectasia causing neuralgia, severe perineal fibrosis, as you can see, white fibrous band here causing trigeminal nerve compression and trapping an arteriole in between. Tumor-related compression. Tumors usually cause neuralgia again by pushing the vessels of various size into the nerve. And very rarely, barring exception of an epidermoid, which is an inflammatory tumor itself does not cause neuralgia in our experience. There has to be a vessel. The implication is that when one removes the tumor, one has to really dissect the arachnoid and purposefully aim for decompressing the nerve for the pain if the patient is symptomatic for the pain with the tumor. And again, as there are variations of the arteries, the venous system of the posterior fossa is more variable. So, starting from multiple petrosal veins near the trigeminal nerve, there can be no vein here and entire venous drainage going near the facial nerve. So, these are extremes of variation, and you can see very large veins, again skeletonized by dissection, and this is the trigeminal nerve. And these are the various, differences in the venous anatomy around the trigeminal nerve. This itself actually is a subject of a major paper which we are in the process of writing. But just to give you an idea what variation one can get in the area of the nerve. So in our analysis, V2 plus V3 was the commonest type of neuralgia, 35%, followed by, of course, V1 plus V2, followed by third nerve only, that is V3 only, and then followed, before that V2 only, that is maxillary, and then V3, and then the other combinations. So just to conclude, we have been operating on these, conflicts for nearly 19 years, and uh, the drawings and videos have enormously helped us. I really invite anyone who is interested in neurovascular conflict syndromes to join our research group, because a lot needs to be studied further. Janetta famously tried to decompress the vagus nerve for essential hypertension, which of course did not work. But there may be many cephalalgias, variations of cephalalgias, which are missed and which can be amenable for microvascular decompression, but it is for the future to decide whether it happens or it does not happen. Thank you very much for your patient hearing. And I'm sorry that I could not, research the trigeminal nucleus in depth in one day's time. But this nucleus is a very complex nucleus. Extreme and tremendous research is being done in the physiology of this nucleus. It is definitely a matter of half an hour talk, because the way it forms connections with the other cranial nerves and causes reflexes and reflex pain syndromes, etc. Thank you very much.
Thank you, Dr. Jaydev, and it's a masterly and lucid talk, and your rich experience has really taught us many things, and the students are very much benefited. Lovely pictures, lovely surgical exposure of the various conflicts and veins. And if anybody has any question, you please ask Dr. Jaydev. He's got a very rich experience in this field, 1800 surgeries or 19 years. It's a mammoth achievement. I think a lot of claps for your achievement. And anybody wants to ask any question? But you are so lucid. Yes.
If MRI is negative and the patient has refractory trigeminal neuralgia, even then
Yes.
surgical exploration is indicated?
Provided there is no history of multiple sclerosis, there is no history of herpes, and of course you have ruled out the tumor. Of course, if there is tumor, you will have to go in, but these two especially have to be ruled out. Multiple sclerosis history at times can be missed. That is my experience, because people don't remember, or they were not diagnosed properly sometime in the past. But yes, if these two are negative, then exploration is indicated. We have a series of about 19 patients. It was 19 in 2022 when we presented that, of people with severe neuralgia post multiple sclerosis, and in whom we had done selective sectioning of the trigeminal nerve, and it had given them good relief. I would say 70 to 80% relief, though not complete cure.
So in these 1800 patients, how many were MRI negative?
Oh, MRI negative patients, actually speaking, were very few. MRI negative patients, we need to really find out, because what has happened, unfortunately, is that we don't have the MRI data of the old patients, one. And secondly, before 2015, the quality of the MRI was different, and now the quality of the MRI is different. But often I can say that maybe there are 2 to 3% who are MRI negative. But when I see the MRI, because I've been seeing this area repeatedly, I see few veins or blood vessels around them. But truly negative MRI, I think 1 to 2% at the most.
And secondly, if there is a neurovascular bundle or compression which is clearly seen on the MRI, and the physician has not yet completed his medical management, would you still recommend to go for early surgery? Means it is early surgery or refractory cases only?
No. That's sorry, I forgot to mention that. With the safety of the neurosurgery, a lot of indications have changed in last 5 to 10 years. But I think, for example, if you want to speak about epilepsy surgery, it is very important to know which group is performing that surgery, because they are very specific and niche surgeries. And if people operating occasionally on epilepsy, you will see bad results. these are, these are not mainstream areas like epilepsy or, neurovascular conflict. So if a experienced group is performing that, I think I would not say that on the next day of diagnosis, but uh, I, practically speaking, I wait till, adult patient exceeds the dose of carbamazepine of 200 twice a day, uh, or as it is tolerable. Also, other practical factors have to be seen. While, some people are allergic to all medicines. In those patients, we have gone in early. But I think the recommendation is moderate neuralgia with, starting of drug-related problems. That is the indication. Moderate timing of the neuralgia, duration of the neuralgia, with uh, drug-related problems appearing and not allowing them to, function normally is the indication. It has to be definitely, I think, aimed at early than it used to be before, because see, what happens in chronic pain syndromes is that the sensory area in the sensory strip for pain goes on expanding. It has been proven with the functional MRI repeatedly. Anybody who has got chronic pain syndrome of any sort, experiences daily attacks of different types of pains. Uh, this central sensitization occurs over the period of time. And these people, even if on doses enough to, stop pain immediately after taking a medicine, there is in between time when they get these attacks and then they take the medicine immediately. So these repeated attacks have an ability to centrally sensitize the system and increase the mapped area of the sensory cortex for pain. And also the brainstem synapses get sensitized and facilitated. That needs to be kept in mind. On the other hand, these people are in continuous dread of the next attack, even if on drugs. They are in continuous dread of the next attack. They say, I have taken medicine at 8 a.m. and now it is 12. My next dose is at 2. So, my God, will I have attack between 12 and 2? So, this continuous foreboding is also weighing heavily on their mind. It causes anxiety. It causes, all sorts of things. So, I think if you're confident enough to operate on these patients successfully, with high success rate, the recommendation has to be earlier than before.
Sir,
Okay.
did you compare
I think
beta-
I think we'll have to stop here because time is around 10 o'clock. Dr. Jaydev, thank you very much. Because Vivek has to give his talk and Dr.
Okay,
has to
thank
give.
you.
Thank you very
Thank you
much.
very much.
And further discussion can be at personal level or on email to Dr. Jaydev. Thank you
Sure.
very much for gracing Neuro Pathshala, and we will request you to take up trigeminal nucleus whenever it is possible in future, and we'll again.
No, I need to study that. When I started reading, so much research has gone into it.
Yeah.
So much research in last few years.
Hmm.
It's fascinating. Yeah, I will certainly do it and come back to you. Okay. Thank you.
They are saying share your email, and we can you can send me, then I'll send I'll put it in the WhatsApp.
Sure, sure.
Okay. Thank you very much, Dr. Jaydev. And
Thank
I
you, sir.
think
Thank you.
very much. Vivek, and we can start. You can start sharing your screen, Jaydev sir. You can stop sharing. Dr. Vivek, and after the very elaborate description of various conflicts, and what the neurologists depend on is, after the pain is diagnosed, we want to have more evidence on neuroimaging, and let us hear from you what you have to tell us.
Sir, am I audible, sir?
Yeah, you're audible.
Yes. So after a very nice talk by Jaydev, sir, and I think he has covered a lot of anatomical points that made my talk a little more simpler. So, sir has told the surgical aspect of the neurovascular conflict regarding trigeminal and all other three nerves. So, my talk will be focused mainly on the trigeminal nerve. So, neurovascular compressions are because of the direct contact causing mechanical irritation of the cranial nerves by blood vessels. So, blood vessels can be artery or can be vein, as we have seen the previous talk. So, there are four nerves which are predisposed for NVCS. First, most common is the trigeminal, followed by the facial, followed by the vestibulocochlear and glossopharyngeal. So, as sir has told earlier also, this contact of the blood vessel with the nerve can be sometimes an incidental finding and patient will be absolutely asymptomatic. So we encounter a lot of MRI where there is a just nerve, there is a blood vessel which is very traversing very close proximity to the nerve. That doesn't mean patient has NVCS. So in appropriate clinical setting, the diagnosis should be made. So arteries are more likely to cause more symptomatic NVCS than veins due to pulsations. Obvious reason is that arteries are pulsatile. They will cause a lot of compression because of the continuous pulsations and subsequent demyelination leading to the thinning of the nerve and neuralgias. And anatomical location, as Sir has clearly told, there is something called as a root entry zone. So that zone is a transition zone between the central and peripheral myelin. So when the any particular blood vessel in a genetically predisposed person comes in contact with the nerve, it leads to the neuralgia. So this transition zone concept I'll elaborate in further slides. So transitional zone is nothing but, as we know, there is something called a central myelin and something called as a peripheral myelin. So central myelin is formed by oligodendrocytes and peripheral myelin is formed by Schwann cells. So after the central myelin finish and peripheral myelin start, that zone is more susceptible for the triggers, and this is typically called as a transition zone. So different author has used different names. Some people call it as a root entry zone, some people call it root exit zone. REZ and TZ can be used interchangeably, and some people has defined it separately also. So for this discussion for practical purpose, the transition zone is applied for all practical purposes. So transition zone varies from nerve to nerve. The most variable nerve is a trigeminal nerve, and transition zone can vary from 3 millimeter from the brainstem exit to 4-5 millimeters. So it's a quite big segment, and anywhere around the transition zone, if any blood vessel is causing compression, will lead to trigeminal neuralgia. So what are the imaging protocols we follow for trigeminal neuralgia is very important for this. So if you're suspecting any person to have trigeminal neuralgia on clinical ground, so these 3-4 sequences are very important. First, we do heavily titulated sequence that are popularly called as CIS3D, Fiesta, or BTFE, depending on which machines you are using. They come in 3D orientation. Now, advantage of this sequence is that in heavily titulated sequences, the CSF will be intensely bright, and whatever the nerves and the blood vessels traversing through that systems will appear very black, and it will stand out as a contrast. So that is why this is the basic of the any neurovascular conflict. You must have to have CIS 3D in 3D orientation so that we can confirm the contact between the blood vessel and nerve in at least 2 planes. Then to define the artery from the vein, we have to do a non-contrast angiography, that is a time of flight angiography in 3D orientation. And nowadays, there are software which can superimpose these 3D images with the top MRI images so that we can clearly see the neurovascular conflict. And to find out any venous source, sometimes the top MRI will not pick the venous source for the conflict. If you're not finding any source, then we have to give a contrast. So contrast can opacify small arteriole or small venule, which is in very close proximity to the nerve and can lead to the neurovascular conflict. So when you are advising any MRI for the neurovascular conflict, the 3 sequence you have to request, that is CIS3D, time of flight, that is top MRI angiogram, and third is a post-contrast T1 weighted imaging. So these 3 sequences, apart from the routine brain sequences, will cover all possible sequences as a comprehensive protocol for neurovascular compression syndromes. So now coming to the trigeminal anatomy radiological perspective, as we know, this is a mixed nerve. It carries a sensory innervation of face and motor function of the masticatory muscle as well as tensor veli palatini and muscle. So it has 3 main branches: ophthalmic, maxillary, and mandibular. The Roman words are V1, V2, and V3. 3 branches join the gastric ganglion in Meckel's cave. So gastric ganglion transmit the sensory information to brainstem via cisternal portion, and this cisternal portion is a typical area where we get a neurovascular conflict. Now, as I sir has already told, the cisternal portion length is variable based on the how roomy is the prepontine cistern. So it can vary from 8 to 15 mm in length. And zone of the central myelin, again, this is a central myelin zone is variable. So they have reported about 4.19 to plus minus 0.81 mm away from the brainstem. So that much variability is there. So if you try to find the transition zone for the trigeminal nerve, you have to look in the cisternal segment of the nerve, and typically about 3 to 4 millimeter distance from the brainstem. Now, nerve nuclei. So there are 4 nuclei, one is motor and 3 sensory. So motor is located in the lateral pontine tegmentum and it supplies the muscles of mastication as well as 2 T's, that is tensor tympani and tensor palatini. Now 3 sensory nuclei are there, out of which one is principal. Exactly lateral to the motor nucleus, the sensory nucleus lies, and it carries the descriptive tactile sensation from skin of face. While the caudal continuation of the principal sensory nucleus is a mesencephalic nucleus. As name suggests, mesencephalic. It is located in the midbrain at the level of inferior colliculus. It carries the proprioceptive sensations from teeth, hard palate, and TM joint. Caudal continuation of the sensory nucleus is a spinal nucleus. It extends till the C3 level of the spinal cord, and it typically carries a pain temperature sensations from the face. So these are the 4 nuclei. Now on imaging, roughly we have drawn the nuclei. So the medial one is nothing but the principal motor nucleus, which is more medially, and lateral to it is the principal sensory. And some caudal cranial extension will be the mesencephalic nucleus of trigeminal nerve located at the level of inferior colliculus. This will be seen in the more cranial sections. So these 2 rootlets will exit and join to form a trigeminal nerve. So this is a cisternal segment of the trigeminal nerve where these 2 roots join and form the nerve. So typical anatomy of the cisternal segment. This is again a typical example of the cis 3D sequence in 3D orientation. We can see this is the axial orientation image and this is sagittal orientation image. So nerves exiting from the lateral tegment of the pons. This is the trigeminal nerve on the left side and this is a trigeminal nerve on the right side. On sagittal orientation, we can see this is a linear hypointense structure coursing from the pons, entering into the Meckel's cave is a trigeminal nerve and it is surrounded by the branches of superior cerebral artery. So this is how the anatomy looks. So on axial also, this is a porous trigeminus, that is a dural ring through which the trigeminal nerve enters the cavernous sinus, and this is a Meckel's cave where the gastrian ganglion is located. So in the cisternal segment of the trigeminal nerve, from the brainstem up to 4 millimeter distance, the transition zone is located. So we have to focus this particular area to find any neurovascular conflict in appropriate setting, obviously. So not only the proximity of the nerve with the vessel, but also there are 3 more important points which I like to emphasize here. First is the displacement of the nerve. Usually nerves will come in contact with the blood vessel very frequently, but if that particular blood vessel is displacing the nerve and deviating the course of the nerve is more of the clinical relevance. Second thing, constant pulsations will cause demyelination of the underlying nerve fibers and leading to the thinning of nerve. So second point is thinning of nerve. And third time, very rarely we will see the hyperintensity along the course of the trigeminal trajectory. So this is somewhere the nucleus will dry, and this will be the trajectory of the trigeminal nerve. On T2 weighted images, sometimes you will find the hyperintense signal going till the trigeminal nucleus. So these 3 signs, if you find on imaging, then patient is more likely to have the significant neurovascular conflict. That's how we interpret on the MRI. Obviously, many of the patient, asymptomatic patient also, we find the contacting blood vessel with the nerve, but every time it is not of clinical relevance. Now coming to the second segment is a Meckel's curve, that is interdural segment. It is a pre-ganglionic segments in the and it ends in the gastrian ganglia. It is also called as a semileural or sensory ganglia, and it always enhances because it doesn't have any blood-brain barrier. So if you give contrast for the trigeminal neuralgia, don't mistook this enhancement as abnormal and something like neuritis. The trigeminal ganglion lies outside the blood-brain barrier, so it will show the enhancement. The motor route will pass under the gastric ganglia and leave the skull through the foramen of OL. That is a typical mandibular nerve. And sensory route divides into the, again, 3 components of the ophthalmic, maxillary, and mandibular, and they'll exit from the anterior aspect of the gastric ganglia. Now coming to the ophthalmic division, this is very simplified talk. I think sir will cover some detail of it. So ophthalmic nerve, as we know, it courses along the lateral wall of cavernous sinus and it lies just below the trochlear nerve and lateral to the abducens nerve. So it leaves the skull via the superior orbital fissure and enter the orbit, where it divides into nasociliary, frontal, and lacrimal branches and provides the innervation to the globe, nose, forehead, and skull. Now, second is maxillary division. Maxillary division also courses along the wall of the lateral wall of the cavernous sinus. It lies inferior to the ophthalmic division. It exits the skull through the foramen of rotunda. And Through that, it continues into a pterygopalatine fossa and gives also some branches. And it typically receives the sensory information from the midface, cheek, upper teeth region. Mandibular nerve is a third division of the trigeminal nerve, and it leaves the skull immediately inferior through the foramen of oval. It doesn't pass through the cavernous sinus region. Motor supply wise, it supplies the muscles of mastication and tensor veli palatini and tensor tympani. And sensory innervation, it carries from the floor of mouth, lower 1/3 of the face, tongue, and jaw. So anatomically wise, this is a schematic representation of the cavernous sinus. You can see the blue structure is multiple fenestrated cavernous sinus. Through the cavernous sinus, the internal cerebral ICA is internal carotid artery is running, and just lateral to the ICA there is a nerve. This is a sixth nerve, that is abducens nerve, and on the lateral wall there are 4 nerves. If you see from craniocaudal manner, the first one will be the third nerve, then it will be the trochlear nerve, followed by the ophthalmic division of trigeminal nerve, which is ovoid and more bigger than the rest of the nerves. And last one is a maxillary nerve. Mandibular nerve doesn't come into the picture because it exists from the foramen oval. Now, same image, if you see the MRI counterpart on T1 weighted images, deliberately I choose T1 weighted image because it cavernous post-contrast T1 weighted image, because here we can see the post-contrast enhancement of the cavernous sinus, the internal carotid artery. The third nerve is here, the very tiny fourth nerve, that is a trochlear, is the thinnest nerve, and we can see this big bunch of the fascicles. This is nothing but the ophthalmic division of the trigeminal nerve, and the lowermost part of the lateral wall of the cavernous sinus lies a maxillary division of the trigeminal nerve. So this is the neurovascular and neuroradiological aspect of the all divisions of the trigeminal nerve. Now on CT, I have just highlighted different foramen from where they exits. So in axial view, you can see there is a superior orbital fissure. Superior orbital fissure is the exit point of the ophthalmic division of the trigeminal nerve, and it typically supplies, it gives a nasal ciliary and ciliary, lacrimal and nasociliary divisions, and it supplies the orbit. This is the lateral wall of the cavernous sinus. You can see the sphenoid sinus, and lateral wall there is a rounded foramen-like structure. This is nothing but the foramen rotundum, and through the foramen rotundum, the maxillary division passes. And there is small structure here. There are nothing but the Vidian canals through which the Vidian nerve passes. And on the axial view, the foramen of oval is seen very clearly. These are rounded foramina. So on the right side as well as on the left side, and these are the foramina from where the mandibular nerve exists and goes to supply the muscles of mastication. So sir has also elaborated that sensory supply by the V1, V2, and V3. This is again a repetition of it. V1 typically supplies the upper eyelid and forehead and the scalp. Ella of the nose, upper lip, and the part of the chin is supplied by V2. Lower lip, chin part, barring the mandibular margin till the tragus, it is supplied by the V3. So this is all about the anatomical aspect of the trigeminal nerve. Now coming to the trigeminal neuralgia, it is the most common neuralgia. Most of the time, it is because of the neurovascular conflict, which is the most common cause. Other etiologies proposed are neoplastic, that is some small tumors like schwannomas can compress, schwannomas can sometimes present, or sometimes extrinsic compression by tumor displacing the arterial and compressing his nerve is also can sometimes lead to trigeminal neuralgia. Inflammatory and infectious condition or trauma can be proposed etiologies. So patients with the classic or idiopathic trigeminal neuralgia have recurrent episodes of stabbing pain in territory of V1 or V2. And typically pain is triggered by the very mild or very trivial stimuli like washing of face, brushing the teeth, or shaving, or for that matter, eating also. And patient will not have any focal neurological deficit. The attacks are like paroxysms, and in between the attacks, the patients are pain-free. However, the longer the neuralgia lasts, more intense pain become and more frequent attacks are. Most often, the conflicting artery will be the superior cerebral artery followed by the ICA. Sometimes we can get the compression because of the dolichoepileptic, basilar, and vertebral arteries, or sometimes saccular aneurysms can come from the basilar artery and compress the trigeminal nerve and cause a neuralgia. Very rarely, an embryological entity called as persistent trigeminal artery arises from the internal carotid artery, or an microavium or a petrosal vein can cause a trigeminal neuralgia. Sometimes, as sir has clearly told, small CP angle system or small prepontine system all structures are very much compactly arranged, and it can predispose patient to develop a neurovascular compression syndrome and lead to trigeminal neuralgia. So proposed practical cutoff for the location of the transition zone, that is a root entry zone, with respect to the trigeminal node is 3 millimeter. And I think this is a reasonable agreement between the different authors. Some authors has proposed 2 mm, some has proposed 4. So we roughly take around 3 to 4 millimeter zone as a transition zone for the neurovascular conflict. Now I'll just share the examples of the cases. So this is the normal anatomy on the CIS3D. So this is the pons. In preponderant system, we can see the basal artery flow. These are superior cerebral peduncles. And from that, you can see there is an exiting linear structure coursing through the preponderant system. This is nothing but the trigeminal nerve on the left side, which is seen very clearly. This is a porous trigemicus, that is a dural cave through which the trigeminal nerve enters into the Meckel's cave, and this is the location of the Gasserian ganglia. So from the exit from the brainstem till the 4 mm, this is a central myelin, and from the 4 mm onward, there will be peripheral myelin. So in between these two, there is a transition zone, and this is a zone where the nerve is most vulnerable from the microtrauma by the arterial pulsions and can lead to the neurovascular conflict. So this is a transition zone or a root entry zone concept, and they are often used interchangeably. Now, typical examples of the trigeminal neuralgia on imaging. I'll just show the normal MRI of the right side. Right side nerve is exiting from the pons. This is a superior cerebral artery, very close to the nerve, but you can see it's not deviating the course. It is not causing any thinning of the nerve. So this side is not symptomatic, but if you see on the left side, nerve is displacing the nerve. Blood vessel, that is a superior cerebral artery loop, is displacing and deviating the course of the nerve. And in comparison to the volume, the left side nerve is more thinned out. So we have found the deviation of the nerve. There is a conflict with deviation and thinning of nerve. So definitely it qualifies to called as a neurovascular conflict. And most often the artery of the culprit will be superior cerebral artery in up to 88%, followed by the ICA. Very rarely we'll get a oligoectatic vertebral or basilar artery, and some very very rare, we'll get a saccular aneurysms or persistent trigeminal arteries causing neurovascular conflict. So focal thinning, deformed or displaced nerve is a highlight of the imaging for the neurovascular conflict. Again, the second example, again, you can see on the left side, very thick nerve exiting from the pons. The SCA is located far away from it. There is no contact, but on the right side, the nerve is clearly deviated in the course, and on medial aspect, there is a vascular loop, probably from the superior cerebral artery, causing the deviation of the course and as well as the thinning of the nerves. Again, if you see the sagittal reformated image, so sagittal reformated image, this linear structure is nothing but the trigeminal nerve exiting from pons, and it is obviously sandwiched between the two loops of the SCA. So this again fits into the definition of the neurovascular conflict. And since patient has symptoms on the right side, we have labeled it as a trigeminal neuralgia because of neurovascular conflict. Now, sir has shown very beautiful pictures of the Teflon pledgets placed for the microvascular decompression. Just one image to show how that looks on post-operative MRI. We can see this hypointense globular structure, which is interposed between the superior cerebral artery and the trigeminal nerve. To separate out the nerve, this is a sagittal view of the same, and this is how it looks on MRI after placing a pledget. So purpose of the pledget is to prevent nerve to coming in contact with blood vessel and to dampen the pulsation and subsequent relief of the symptoms. Now, very rare example of neurovascular conflict. Just want to show. This is of the academic interest only. Very rarely we see such kind of picture. So this is a top MR angiogram image showing the cavernous ICA, and one small channel, vascular channel, is arising from posterior genu of the cavernous segment of the ICA. It is coursing toward the basilar artery, and it is having some conflict with the left side trigeminal nerve. So any vascular channel coming from the cavernous segment of the ICA from posterior genu and connecting to the basilar. So these are the persistent carotico-basilar anastomosis, and typical example is a persistent trigeminal artery. And this trigeminal artery is causing deviation of the course of the nerve and thinning of the nerve. You can see nerve is deviated superiorly, nerve is indented by the artery from below, and there is a thinning of nerve. If you see the nerve thinning here, nerve caliber on the right side is very much thick, and near RE's head, the nerve on the left side is the shows focal thinning as well as deviation of the course. So this again qualifies into definition of the neurovascular conflict caused by the persistent trigeminal artery. So again, very rare cause is that a prominent vein. Prominent vein, that is typically we get a petrosal vein draining into the one of the petrosal sinus, causing the deviation of the course and thinning of the nerve. So nerve causing trigeminal neuralgia. Again, 6-3D sequence is here. You can see the right side nerve, left side nerve is also seen. But on the axial plane, you are not able to see any deviation or thinning of the nerve. But if you see the image in the sagittal plane, you can see nerve is definitely thin out where the vein is making contact with REZ, and it is showing the upward deviation of the nerve. So there is a deviation of the nerve, there is a thinning of nerve, vein is coming in contact with under surface of the nerve. So this also again qualified into the definition of neurovascular conflict, and we diagnose this case as a neurovascular conflict due to the petrosal vein. So this is all about the radiological perspective of the trigeminal neuralgia. The take-home message from this talk is that many of the times we see vessels coursing very close proximity to nerve. All vessels will not cause the trigeminal neuralgia. It is a thinning of nerve, deviation of the course, and sometimes the hyperintensity along the trigeminal trajectory. These are the three key points of the imaging we have to remember. And when we find such kind of case in appropriate clinical setting, the diagnosis is very obvious of the neurovascular conflict due to trigeminal neuralgia.
Well, thank you, Dr. Vivek, and really very nicely shown all the conflicts and where students have to look for the evidence if there is any conflict that is happening. All the vessels have really nicely shown on the neuroimaging. And thank you very much for the excellent talk, Vivek. And if anybody has any questions to Dr. Vivek, you can type in the Q&A chat box, and they'll be there for some more time and he will answer. In the meantime, may I ask Dr. Aradhana to present her paper, and then we'll wind up today. Dr. Vivek, if you are there for some time, you can stop sharing, but they may ask some questions if they are there. Otherwise,
Yes,
you
sir.
can share their email if they want, then they can ask. Okay. Thank you
Yes,
very much once again. We had a nice talk. So we'll go on to next last presentation, that is by Dr. Aradhana. Are you able to share, Dr. Aradhana?
I'm trying, sir.
If you have an issue, then we'll postpone it to the next week.
Can you see,
not-
sir?
No, I'm not seeing anything. I think there are some technical issues, Aradhana. Then I think we'll take up your paper next week. Okay? You can
Sure, sir.
Huh?
No problem. Yes, sir.
Right. Thank you very much, all people who have attended. If there are any questions, you can ask before I wind up till next Friday. If there are no questions or comments, you can unmute and talk. Otherwise, from my side, till next Friday, it's good night. Thank you very much.
Good night, sir.
Good night.
Thank you, sir.
Jai Hind.